So we have to differentiate between infarct and hemorrhage, which is what is required in the ER setting. Why do you think it is important?
Because in infarct you gain a small area focus, where hemorrhage can go from focal to generalized. It can take more space.
My question is, why does a physician in the ER want to differentiate between infarct and hemorrhage? Treatment. He wants to, obviously you want to treat the patient. You want to do, if it's an infarct, the treatment is different from an hemorrhage. What would you do with an infarct?
TPA.
Yes, anyone?
TPA.
TPA, you would give him anticoagulants. You would try to dissolve the clot. If he presents earlier on, you can sort of completely dissolve the clot and save the brain. So the management point of view, if it's a hemorrhage, you will not give him anticoagulants. Why? Because he will further bleed. Obviously, we don't want him to bleed further. So it depends. The management point, from my management point of view, we have to, once you do a CT scan, you're trying to differentiate, is it infarct? Should we put him on aspirin or anticoagulants, or should we just leave him because of, if it's a hemorrhage, you cannot give him anticoagulants, or you cannot put him on aspirin. Okay, so this is just to tell you, before how to differentiate, you must know the densities that you see. You have a basic idea from the first lecture, but just to remind you again, you see the brain is gray tissue here. This obviously white is the skull bone. So the densities are different. The black here is CSF in the ventricle. So black means fluid, gray means soft tissues, and white means bones on CT scan. Okay? So if you look at this gray tissue here, it is different from this gray tissue here. What is the difference? This is more darker. So it is more like, it's more like hypodense. Remember I told you in the first lecture, you try to classify hypodense, hyperdense, isodense. So this is what I am trying to do here again. Hypodense means hypodense to something. The brain is hypodense, means low or low density compared to the surrounding brain. We are comparing it with the surrounding brain. So you see this brain here is more bright compared to this brain. So this one is hypodense compared to this brain, which is not normal. Similarly, if you look at this here, this is bright. It is hyperdense. It is hyperdense to something like the surrounding brain. Look at this now. This is isodense. This thing is same as the surrounding brain parenchyma. So you have hypo, hyper, iso, same. Okay. So this one is actually an infarct. And where is this infarct? It is in the right MCA territory. If you remember my first lecture, I told you this part here in front of the ventricle is the ACA territory. This one here is the PCA territory. So this one obviously is a large area which is covered by the MCA. So there is a large infarct in the MCA territory. Now what is going on here is a bleed. This is a hemorrhage. And remember I showed you the basal ganglia structure, the anatomy of the basal ganglia. I told you usually the hypertensive bleeds occur in this area where you have the head of the caudate, the thalamus, the anterior limb, posterior limb of the internal capsule, and then you have the lentiform nucleus and the claustrum on the lateral aspect. So remember I told you if you have a bleed in this part, it is hypertensive bleed. Okay? So this is hyperdense compared to the surrounding brain. Now, if you look at this one, this is also a bleed, but it is isodense to the surrounding brain parenchyma. This means this is not fresh bleed. It is a subacute or a bleed after 2 or 3 weeks.
What's the white stuff in the ventricle?
This one is calcification in the choroid plexus. This is normally seen. If it is subacute or say after 2 or 3 weeks, it will become isodense like this. And at times you would have to, it will be difficult to differentiate from the surrounding brain parenchyma. So you have these Hounsfield units in the system where we can measure this. If you measure the blood here, it will be around 70 Hounsfield units. If you measure the soft tissues here, it will be around 30 to 40 Hounsfield units. Okay? If you measure here, the Hounsfield units will be around 10 to 20 Hounsfield units. So the computer can also help you with measurements of the Hounsfield of the density. Now let's see more examples. This is the same thing that I just showed you. How is it different from this?
The one on the right is was more.
If you look at this, this has a very well-defined margin around it. You see, it isn't in a vascular territory. You see, if it is a vascular territory, why would it have a margin around it or capsule around it? It would not have a capsule or a margin well-defined around it. So this appearance where you have a well-defined structure, round structure like this, it is very similar to the CSF here. So this is a fluid-containing cyst in the brain. Compare it with this one. This is an infarct. It is in the vascular territory. It doesn't have a well-defined margin, not a sharp margin like you have it here. You understand? So this is how you differentiate between an infarct and a cyst. A cyst obviously would have well-defined margin and it will not be in the vascular territory like this one. Okay? Now if, yes please.
The cyst is having old hemorrhage or CSF?
It's just fluid inside. If you look at it, it looks very much similar to the CSF. Okay, so we are not actually telling what exactly it is. It can be any cyst, like hydrated cyst. It can be a simple cyst, neuroepithelial cyst. It can be anything. But as far as we see that this is fluid-like. So we'll say a fluid-containing cyst. Okay.
Can we please redo the concept of hypodense?
Okay. So you want to go back to this. Hypodense means, hypo means, what does hypo means? Less. Hyper means more. Iso means same. Okay? So hypo to something. Hypodense to the surrounding brain. Hyperdense to something. What? Brain. So we are talking about the brain here is hypodense to the surrounding brain. The brain here tissue is hyperdense to the surrounding brain. And here the brain tissue or the tissue here is isodense to the surrounding brain.
So are we rating the density based on the signals you receive?
Based on the Hounsfield units or the density that you perceive, that you see.
So can I say that a hyperdense region is sending out more signals as opposed to a hypodense region?
It appears more bright. It's not signals in a CT scan. It's the density. When we talk about CT, we are talking about density. Signals is when you talk about MRI. Okay? So if it appears bright on MRI, then you would say it is sending more signals. Okay? Okay, so now let's see this cyst. Again, there is fluid inside, but how is it different from the previous cyst? You see there is this bright area around it. The margins are bright. And you see some area like this. Now, if you see a cyst with some bright margins around it, you have to make sure, is it pre-contrast or post-contrast? So you need to get information whether contrast was given. Maybe this is a post-contrast scan where the margins have enhanced after giving contrast. If it is without contrast, then this high density can be calcium. Simple calcium in the wall of the cyst. Okay, like the calcium you saw here in the choroid plexus. So you need to know on CT scan whether the contrast was given or not. So obviously you would be able to, there are these parameters that would tell you whether contrast was given. If there was contrast given, then you need to compare with the scan which was without contrast to see if there is any enhancement. So this is, actually I have not given you the cyst where there was no contrast given. So this is post-contrast scan where you have enhancement in the wall of the cyst. Okay, so this is not a simple cyst. It's a cyst with enhancing walls. Now, if you have a cyst with enhancing wall, ring enhancement, we call it ring enhancement, and there is surrounding edema. You see, there is low density around it. You see, compare it with this gray matter around it. So, if you have a ring enhancing lesion in the brain, it's most likely an abscess. Okay, it's most likely an abscess where you have a ring enhancing lesion. Now, why doesn't this stuff here in the middle enhance? Does anyone have an idea? What is an abscess? What are the contents of an abscess? There's pus inside. So there are cells. It's not actually the pus, the necrotic material will not take up contrast because there is no blood supply to that necrotic material. Okay, understand? So that is why this center part doesn't enhance, but the wall does enhance. The inflammation of the wall takes up contrast. So this is how we differentiate between a simple cyst and a complicated or a complex cyst, by giving contrast. Now if you look at this, what do you see here? Is it hypodense or hyperdense? Hypodense. So how is this hypodense different from the other hypodense? It does not have a well-defined margin. You see, it has finger-like projections. You see? So it doesn't sort of give you an appearance where it is in the vascular territory. You see? It has sort of finger-like projections. So it's not sort of appearance of an infarct. So when you see something like this, it is known as edema, where you have finger-like projections going here and there. It doesn't have the well-defined margin like a cyst and doesn't sort of, follow the arterial territory. So this is how the edema looks like. Okay. Now there are two types of edema. I wouldn't go into that much detail. Obviously for second year it's too much. There are cytotoxic and vasogenic type of edema. Just for your information, the cytotoxic one is where... Have you read about it?
Yes.
So cytotoxic is usually with infarcts, and the vasogenic is with inflammations and tumors. Okay? The vasogenic one is where the blood-brain barrier is defective. The cytotoxic one is where the membrane gets, compromised. The sodium and chloride across the membrane gets defective. So increased water, when there is injury to the cell, water from extracellular space goes inside the cell and it swells up. And resulting in swelling of this cell, it appears bright on T2 later. We'll see this later. Okay, so more examples of infarcts. How the infarcts vary or at different locations. Now compare this area with this area. What do you see? Which one is hypodense?
Left side.
The left one. This one is hypodense compared to this one. Now compare this area with this area. Which one is hypodense?
Right side.
The right side. This part is hypodense compared to this area. So obviously you have this nature giving you two sides to sort of make a differentiation. Now compare this area here is with this area here. So what do you see? This is again hypodense or low attenuating compared to this tissue here. So now if you come back, the first one is an infarct again. Again, it's in the left MCA territory because it is sparing the anterior frontal lobe and the occipital part here. Okay, so again it's in the MCA territory. This is all MCA territory. This one is again MCA territory, but it's in the posterior division. So the MCA territory has anterior division and the posterior division. So this infarct is developing in the posterior division of MCA. Again, there is sparing of the occipital part here, which is supplied by PCA, and the anterior part, which is supplied by ACA. Now look at this. This one is an infarct, which is, now someone was asking me, why doesn't it look like fluid? Now you can see it is like fluid. So this one tells you this is a chronic infarct. It is there for some months or years. So it is now very much similar to the ventricles now. So this is chronic infarct in the PCA territory. You don't see any brain tissue here on the medial aspect like you saw it here. Okay? So this is how you tell from the location and from the density what it is. Is it infarct, acute infarct? Is it chronic infarct? Or where is it? Okay. The first lecture I gave you was just to tell you the territories. Now we are putting this into practice. Now tell me, what structure lies in front of the cerebellum here? Okay.
Pons.
Okay. Now what is this part? Medulla. What lies above the medulla? Pons. And this is the midbrain. So this one is the pons here. Okay? So I told you at the level of the cerebellum where you see the fourth ventricle, the structure that lies in front is the pons. This is from my first lecture. Now you saw normal pons there. Now this is abnormal pons. Why? Because you see the density of this pons?
Yes. Hypo.
It is hypodense. So this means there is an infarct in the left side of the pons, which is a recent one. Why? Why is it recent? It's not so much liquefied. It's not black that you just saw previously. It's not like CSF. Okay? We are talking about CT. You're not talking about MR. Okay? So here you see an acute infarct or a recent infarct in the left pons. Okay? Everyone clear on this? Now let's see another example. Yes?
So that picture was isodense?
No, it's not isodense. It's hypodense. Compare it with the surrounding brain. Yes. Edema, as I've told you, edema doesn't have a sort of well-defined appearance to it. Okay. It can be an edema. Then, so what would you do next if it's an edema? If you suspect edema? Yeah, obviously you will have an acute history of infarct. And then if you suspect some lesion there with an edema, you will give contrast. Okay. Okay, so now we see another case. This is the same patient. From upper part, we are taking sections from vertex downwards. So these are the upper sections, and then these are the lower sections. This is where the thalamus is, and this is where the lateral ventricles are, and this is where you have the parietal area. Remember, above the ventricles, you have the parietal area. Now tell me, where is the abnormality?
In the
Right side, and it's in the anterior branch of the MCA territory. Why? Because again, you see this part is spared. The frontal part, which is supplied by the ACA, is spared, and you see the occipital part is spared. So this is again in the MCA territory, which is the anterior division. Why? Because the posterior part is again spared. If this was all black like this, then we would have said the whole MCA is involved. Yes. Middle cerebral artery. Middle cerebral artery. ACA means anterior cerebral artery. PCA means posterior cerebral artery. Okay? So you see an infarct which is in the anterior division of the MCA, because all of the MCA territory is not involved. This part is spared. This is also MCA territory. So this means only the anterior branch is involved. Now how does it look like? Is it acute or chronic? Some say acute, subacute, some say chronic, but it doesn't look acute. Why? Because it's more dark. Compare, it is more dark it is very much similar to the CSF. So it's a chronic one, unlike the one that you just saw in the pons. Okay, so it is more like CSF. So we know this has been there for some time. Okay. Now, this is another example of an infarct. How is it different from the previous infarcts? What do you see here? You see some high density areas. So you have hemorrhage within an infarct. So when do you get an hemorrhage within an infarct? Do you know the idea? How could you get an hemorrhage in an infarct? He's right. If you give anticoagulants for treatment of infarct, you can sometimes develop hemorrhage. It is around 5 to 10% of cases develop hemorrhage. How does this happen? Actually, the capillaries become leaky and the blood comes out. Okay? And sometimes it is reperfusion. The area tries to reperfuse itself, and the vessels there, the capillaries are already damaged and they become leaky. So the area where you had an infarct, the vessels there are abnormal and they are leaky and weak. The walls are weak, so the blood comes out with pressure when it tries to reperfuse. So this is the concept behind. The infarct has few high density areas which suggests this is hemorrhaging infarct. So what would you do? You would stop anticoagulants?
No.
Okay. Tricky question. This is what the clinicians come and ask us. Okay, is it hemorrhagic infarct? Should we stop coagulants?
Yes.
No.
So you have to be very careful in this. It depends what type of, is it hemorrhagic infarct due to arterial or is it due to venous infarct? Okay, if it's a venous infarct, then you should not stop. If it is arterial, then you should stop.
What about the
Okay, this is simply too much for you at this level. So we'll talk about this later. But just remember the diagrams that I've just shown you, these are the capillaries where they get damaged in the infarcted area and the blood leaks out once the brain tries to reperfuse after anticoagulant therapy. Now, how the hemorrhage looks like. You already saw the first case. Yeah.
How can you tell if it's venous or arterial?
I'll come to that later. Hemorrhage is bright. Acute hemorrhage is bright. So this is bright here. This is bright here. Where is this blood? Ventricle. So this means this hemorrhage is quite extensive. It's not only in the brain parenchyma, it is spilling inside the ventricles as well. So it is quite extensive hemorrhage. Okay, you see the hemorrhage is inside the ventricles and it has mass effect over the brain. So this is acute hemorrhage. So remember, acute hemorrhage on CT would appear bright like this. And it would sometimes, if it is quite extensive, unlike the example where I showed you, the first one, this is quite extensive. You see, you can see it in the ventricles and in almost all images. Now, once you see something which is bright, that doesn't mean it is hemorrhage always. Calcium also appears bright. You saw the choroid plexus. Now, what do you see here? Which part is this? From your first lecture, which part is this? Basal ganglia. What do you see here? This is the head of the caudate. Okay, this is the thalamus. So there is calcification inside the thalami, inside the lentiform nucleus. See, this is the region of the caudate head, and this is the posterior limb of the internal capsule. So you have lentiform calcifications on both sides. Now, if I say this is hemorrhage, would you agree?
No.
Why?
It's symmetrical.
He's right. Looks very symmetrical. Why would you have a hemorrhage which is so symmetrical? Cannot have a hemorrhage which is symmetrical. Look at this hemorrhage. It's not symmetrical. It's on one side. So hemorrhage is supposed to happen on one side. It cannot be, very much similar. Look at this, almost identical on both sides. Cannot be hemorrhage on both sides. And if you are still not sure, just measure the Hounsfield units inside. The Hounsfield units in the calcium would be above 100. And if it is hemorrhage, it will be below 70. Okay, so you can differentiate from the computer as well. But make from your common sense, cannot be so symmetrical at the same time. Yes. You see something bright, it is hemorrhage. Now you have to tell where is it. Obviously the management again is different for different hemorrhages. So you have to differentiate the site of the hemorrhage. Okay. Now, if you remember from your anatomy, the first lecture, or even from your anatomy classes, there are 3 layers of meninges. Do you remember them?
Yes.
Which one is the inner one? Pia mater. The outer one?
Dura.
The outermost is the dura. The middle one is the red one is the arachnoid. So you see, there are few potential spaces between these 3 membranes. Okay, these are actually the meninges. So the one on the outer side is very much in contact with the skull. This is the dura. The one that is between the pia and the dura is the arachnoid. And pia mater is the one which is sort of just sort of going along the brain convolutions. So it is actually dipping inside the brain sulci. Okay, so it's very much in contact with the brain. Now, the space that lies above the dura is known as epidural space, or the epidural extradural space. The space that lies between the dura and the arachnoid is subdural. The space that lies between the arachnoid and pia mater is subarachnoid. Simple as that. Sub means below, epi means above. So anything above the dura, close to the bone, is epi or extradural. The space that is below this is subdural, and the space below the arachnoid is subarachnoid. Makes sense? Now, what is intraparenchyma? Within the brain. So any hemorrhage inside the brain, the examples that I just show you were intraparenchymal. Now we have to see these 3 examples. How does the epidural or extradural blood look like? How does the subdural blood look like? And how does the subarachnoid blood look like? Now, as far as the epidural or the above the dura, that is between the skull bone and the dura mater, this is the hemorrhage. You see, again, it is dense. Okay, it is lens shaped, or you can call it biconvex. It's something biconvex. You see, it is convex on the inner side and convex on the outer side. Now, why is it important? It respects the sutures. So it will be limited where the sutures lie. You see, there is a suture here. The frontoparietal region, there is a suture here. Similarly, the parieto-occipital region, there is a suture here. It will not cross the sutures. So you will have it being limited by the suture. That is why it is taking a shape of convex, a lens-like shape. Now remember, this blood is arterial blood. Okay? Remember, epidural or extradural blood is arterial blood. When we talk about epidural hemorrhage, it means some artery is bleeding. Now, usually it is middle meningeal artery, if you have it here, this area. And remember, the middle meningeal artery, unless you sort of go in and clamp this artery, it will keep on bleeding. And what would it do? It will start putting pressure over the surrounding brain. And the patient would lose consciousness over a period of time, obviously, unless you release this pressure here. So what you do? The surgeon goes in, makes a burr hole here in the skull bone and drains this blood. You have to relieve this compression over the brain. Your brain cannot, continue like this. You have to release or get rid of this blood in the epidural space. Now, this is the example of subdural space. You see a hemorrhage which is going all the way from the frontal to the occipital region. So it is not respecting the sutures. Okay? It's not being limited by the sutures. And if you look at it, it's not biconvex like the one that you saw earlier. The inner side is concave. It's like this. It's not like this. So inner side is, this side is concave. If you may see here, this is concave. It's not bulging inwards or putting that much pressure over the brain. So when you see something like this, where it doesn't respect the sutures and crosses the sutures, and the inner margin is concave like this, it is subdural. Now, why are we interested to know about this? Because obviously these meninges, you cannot see them here. Can you see the meninges? No. You cannot see them. They're so, all of this is blood, and you cannot differentiate which part is, arachnoid matter, which is dura mater, and which is pia mater. You know from your anatomy that there is these membranes, but obviously on CT you cannot see these membranes. So from the shape and appearance of the hemorrhage, you are able to tell what type of hemorrhage it is. Now let's see another example. This one is inside the brain parenchyma, intraparenchymal. Makes sense, it's in the brain. But what about this one now? Where is it? Subarachnoid. Why? Because I told you the pia mater sort of takes the shape of the sulci. Wherever the sulci dip in, this pia mater follows it. It's covering the brain. So the blood in this space, which is subarachnoid space, would go inside the sulci, and these are the sylvian fissures. You remember the subarachnoid space. So wherever there is CSF, the blood would go into the CSF. So you would see blood in the sulci, in the sylvian fissures, in the ventricles, along the fissures. It depends wherever the subarachnoid space is. So it will be different from the epidural or subdural hemorrhages. We'll see more examples of this. Just wait. Now, the last examples for hemorrhage that you should know of is this one. What is this hemorrhage? It's intraparenchymal, but it is intraparenchymal in an atypical area. It's not the basal ganglia where you have hypertensive bleed. So it's in the frontal region. It's trauma. Actually, this patient hit his head. There was acceleration, deceleration rapid. The brain is mobile inside little bit, so it strikes the skull table from inner side, and this brain gets injured here, and you see hemorrhage. So when you see hemorrhage in the frontal region or in the occipital region, if it's in the posterior part gets hit, so it is known as contusional injury of the brain, and you see hemorrhage here. Okay. Now there is another type of injury which is known as diffuse axonal injury. Do you know what is diffuse axonal injury?
Yes. When
What?
the densities of the nerve, the gray and white matter mixed together, and they end up getting ruptured.
Okay. The basic concept is the white matter axons. You know they have long tracks in the brain. Okay. So sometimes you would have these small petechial hemorrhages in gray-white matter junction where these axons are. Actually, again, it is a sort of acceleration, deceleration injury where the brain gets injured inside, and these hemorrhages are very difficult to see. They're very small injuries, and the patient goes into coma. So at times, it's very difficult to diagnose them unless you find these hemorrhages in cortical, subcortical location along the corpus callosum, so different areas where these white matter tracts are densely packed. Okay. So remember, trauma can result in diffuse axonal injury like this, or can result in contusional injury where the frontal horns or the occipital horns get involved. Now this is just a repetition. I told you the epidural space has arterial blood, that is why it is red here. The subdural space, which has a concave inner margin, has venous blood, which is slowly, the subdural blood is actually slow blood. So it gives you time, it doesn't put that much pressure. Sometimes these are old people who fall on and off, and they come to the ER, and once you do a CT scan, you realize, oh, he has a subdural. So it has been there for some time. It's not acute emergency, unlike the epidural hemorrhage. Now, which one is epidural and which one is subdural?
The light one is the
This one is biconvex epidural. It is being limited by the suture here, which is between the frontal and parietal lobe, prefrontal and parietal bones. This one is crossing all the way around, so it doesn't respect the sutures. It is subdural. So now you can easily differentiate. Okay, everyone clear on this now? You can easily differentiate once you see a trauma patient in an ER and you see something like this. You will tell, oh yes, this is the epidural. Oh yes, someone taught me this is subdural. Why? Because it's not respecting the sutures. No, this is the fox in the midline. So this table tells you what I have already told you. Subdural is concave configuration on the inner side. It is biconvex. Okay, the epidural or extradural is arterial blood, and this one is slow blood. That is why it is venous blood. It crosses the sutures. This one doesn't cross the sutures. Okay. Now tell me, what is this? Looks like an epidural?
لا في الفور
Why?
في الفور
Okay, so this is a pitfall. Sometimes you would have an enhancing lesion which mimics a hemorrhage. So make sure you ask for a pre-contrast CT. So this is a pre-contrast CT. You see, no contrast was given. Here, you see this thing here. So this one has taken up contrast after injection of IV contrast. So this is a tumor which is the commonest one coming from the meninges, is meningioma. So any extradural tumor which enhances brightly like this after contrast is a meningioma unless proven otherwise. Okay, so the commonest benign tumor of meninges is a meningioma. I told you, I think this is again a repetition from my first lecture. Another example of a meningioma, this time it is MRI with post contrast. This is the same patient, this is coronal, this is the sagittal. So the MR has multiplanar imaging, giving you more details. Yes?
The contrast is for the meningioma.
The contrast that you give is taken up by the meningioma. The tumor is vascular.
So it's specific for the meningioma.
No, the contrast that we give is for all tumors. But the meningioma enhances completely, unlike the other tumors. It has homogeneous enhancement.
Why can't we see other blood vessels?
Why can't you see the other blood vessels? You can see them here. These are the blood vessels here. You can see the blood vessels. These are the blood vessels. Okay. Now, for a meningioma, remember it comes from the meninges. Now there is a sign which is known as dural tail sign. You see, thickening of the dura adjacent to this meningioma. This is dural tail sign. Okay. If you look at this, this dura is thickened here. So dural tail sign confirms this is a extraaxial tumor which is meningioma. It's not from the brain parenchyma. Now, we talked about hemorrhage. Acute is when you have it within the first 3 days. Between the first 3 weeks, it is subacute. and after 3 weeks it is chronic. Okay, so if you want to divide it according to the days or time, this is how it is. Below 3 days it is acute and it should be bright. Subacute is between 3 to 21 days. It is isodense, and chronic one is when it gets liquefied and it becomes hypodense. Okay. Now tell me which one is which?
Which?
Subdural. Why? Because it crosses the sutures and has concave inner margin.
Yes.
What is this one?
Also subdural.
Also subdural. It crosses the suture, which is the frontoparietal suture here. Which one is this? Which one is this? You see, hardly you are able to differentiate it from the brain tissue. You see, it is isodense. See, this is hemorrhage here, which is isodense. This is also there on the other side, but it looks like the brain tissue. So for a new beginner, you will say, oh, this is normal brain. But actually, there is blood here, which is isodense. Okay. Now this is again, it's going towards chronic. Some part of it is isodense. Here it is chronic. You see, and there is also an infarct in the frontal lobe here. Okay. So you can, from the density, you can tell is it acute, it is subacute, or is it chronic. Now these are 6 or 7 scenarios that I will just go through, more like the ones that you would get in the exam, very much similar. Okay, 50-year-old man with head trauma was initially conscious, but now 3 hours post-trauma has had sudden decrease in neurological function. So from the history, what do you think? He has some sort of problem in the brain. He was normal initially, but after 3 hours, he suddenly has lost his neurological function. He's become unconscious now. So what do you think is going on? Epidural. More likely epidural, because this is something rapid. It's subdural is slow process. It's a venous bleed. So this is what you get. This is the patient CT. So you have an epidural in the right parietal region. You be wary, sometimes there are also fractures associated with this. Yes. This is another example of another patient, but how is it different from that? Again, there is an epidural, but this time, what do you see here, these black areas? Pneumocephalus. So this means there is also air associated with the hemorrhage, and this means there is a fracture, because air cannot come from inside. It has come from outside. So there is a fracture here. If you look carefully, if I change the window for you, there is a fracture here. So this air has come through this fracture line. So obviously the air has entered the skull, and you see hemorrhage and pneumocephalus. Good, well done. Now the case one we just went through, it is the hemorrhage result of tear of meningeal artery. So you have to go in and clamp the artery or make a burr hole and release the pressure. Okay, so this is what I told you. There is a period of lucidity after trauma, and then the patient deteriorates. So you have a time window where the patient thinks he's fine, but he just collapses afterwards when the pressure over the brain gets more. It is biconvex extraaxial connection between the skull and the dura. You know this now. Okay, another pitfall. What do you think it is? Yes. Why a meningioma? Because the dural tail sign is here. Very, very well done. You see? There is a dural tail sign. It looks biconvex like the epidural, but the problem here is you see the enhancement of the tail. So you need to ask the person, I need a pre-contrast to see whether this was, the same density or soft tissue before contrast. Because after contrast, this is enhancing. Okay. Now tell me, what is this? Another meningioma. Remember, meningioma is coming from, it is not the skull which is surrounded by meninges. You also have meninges in the subarachnoid, in the spine as well. So this is again outside the cord, extradural, but extramedullary intradural. Extramedullary intradural. Remember from my second lecture? The commonest tumor in the spine is meningioma again. Why it is black? Why is it black? What is black? Black is, what is black here? Bone. It's calcified. So meningiomas can also get calcified over a period of time. It's a tumor which is benign and can get calcified. That is why it is black. But sometimes when they don't calcify, it is something like this. When you give contrast, they enhance. Again, it is adjacent to the meninges, and you see it is outside the cord. So the intradural extramedullary most common tumor here is a meningioma.
inside and this one is
Yeah, both are MRI. This one is a T2 weighted fat suppressed image. This one is a T1 weighted image where it is again low, but here on post contrast it enhances. Okay, another case, 45-year-old female presents with thunderclap, so severe headache, vomiting, neck stiffness. Emergency unenhanced CT was done immediately, which reveals high density along the sulci. You see these high density?
Yes.
And in the cisterns where you have the CSF. So it doesn't fit into epidural, it doesn't fit into subdural, it doesn't fit into intraparenchymal. We are left with subarachnoid. Where the CSF is following where the CSF is. Circle of Willis like appearance where the cisterns. Remember the cisterns I told you? These are the cisterns. The ambient cistern, the interpedunculaur cistern. So this is where the CSF should be. The blood is there. Instead of the CSF, you have blood there. And the sulci where you should see, CSF, you have blood here. Okay? So this is subarachnoid hemorrhage. Yes?
This is considered as contusion.
No, it's not contusion. You see, this patient presented with headache and vomiting. So that means this is a sudden presentation. No history of trauma. So what do you think is the cause for this? Aneurysm. The most commonest cause for subarachnoid hemorrhage is a bleeding aneurysm. So what would you do next? Before that, you have to identify where is it. So what would you do? You would do CT angio to identify which aneurysm, which part of the arteries. Where is this aneurysm located? Because from here you cannot tell the CSF. Wherever there is blood, you cannot tell which part of the aneurysm. The surgeon will ask you, where do I enter? Which artery is it? Okay. So you do a CT angiogram. Which of the following is most appropriate next investigation? You do a CT angiogram because it is quick, fast, immediate. You cannot wait for the MR. It would give you details, but CT angio is the most appropriate one because he's already in the CT suit. He's already there. Give him contrast and try to localize the aneurysm. And immediately shift him to the OR, tell the surgeon there's an aneurysm of ACOM or MCA or ACA, then he will plan surgery accordingly. Yes, you do give contrast. Okay? With CT angiogram you need to give contrast. But with MRA you have the option of not giving contrast. Okay, next case, 82-year-old male with mental status change after fall. Okay, so this is what you get. What is it? So simple. 80-year-old, I told you these babas come in again and again. They keep on falling in the bathroom, slip in the bathroom, and once you do a CT scan, you find a hemorrhage there. And it is not actually arterial, it is slow blood which is venous. So it doesn't follow the sutures and it crosses the sutures. Okay, next case. So this was venous blood. I've told you it is in old patients. 50% do not give history of trauma. They just come drowsy. 24-year-old motorcyclist brought to emergency department following road traffic accident. He is found unconscious at the scene. CT brain shows scattered frontotemporal, subcortical, periventricular, white matter, hyperdensity. Diffuse axonal injury. Good. So now you see, history makes sense. Okay. So you see these hemorrhages.
Yes.
He's unconscious. He will not tell you what is wrong with me. You do a CT scan, you find out, there are multiple hemorrhages. He has a severe injury. And usually these people remain unconscious. It's very rare that they come out of the coma. If the injury is severe, they will not come out of coma.
Is it severe?
Yes, it's severe. Okay, 72-year-old man with history of diabetes presents slurring of speech, right-sided weakness. So it's a CVA, which spontaneously resolved. It's not CVA, it resolves. So it is TIA, transient ischemic attack, over 2 hours. Initial non-enhanced CT is normal. Obviously, in TIA, you would not find infarct if it becomes normal after 2 hours. Further investigation by MRI is requested. So the clinician wants an MR. What sequence is more sensitive for diagnosing acute ischemia? Now for the first lecture I told you, I taught you, which you think is the most... Okay, now let me give you these images. Which one is this? I haven't labeled them for you. This is the flare, okay? So this one is diffusion weighted image. This is diffusion weighted image. This is apparent diffusion coefficient, which is a sequence which comes with the diffusion weighted image. Here is, you see, these are all MR sequences. So we are trying to figure out which sequence is more sensitive in the first few hours, and it would tell us about the acute ischemia. So if I was to tell you it is not flare, it is not T2, it is this sequence. This is a new sequence which has just come up a few years back, and the images that you do get is something like this. Now look at this flare, or this is, I told you flare is more sensitive, it's a T2 weighted image. This one has a lesion here. It doesn't have it. The same patient, flare doesn't show this lesion. But if you do a diffusion weighted image, it will appear bright here. And this is ADC, which compares or tells you whether this is acute or whether this is chronic. So we have this sequence coming with this. It tells you whether it is acute or whether it is chronic. In diffusion weighted image, if something is bright and it appears black on ADC, which is called as apparent diffusion coefficient, you can read about this if you want to go into the physics. It is known as, it is acute infarction. You see how acute it is, it doesn't appear on flare. So obviously you will not see it on CT. So this sequence, which is the diffusion weighted image, is the most sensitive sequence for any. If someone asks you what you should do for a TIA or an initial infarct, you would tell him it should be diffusion weighted image. Now again another example where you have a large infarct in the which territory? MCA. You see the anterior one is spared here, AC is spared here. This is the MCA territory. Now compare diffusion weighted image here, which is bright here, and compare it with ADC, it is black. So again, this confirms this is acute infarct. If it is bright on ADC, it is not acute. It is chronic or subacute. I don't want to confuse you by telling you more details about MR. Obviously, you can focus on only one thing at a time. For MR, you need a separate lecture where I can tell you how these infarcts and hemorrhages appear. But if someone asks you what is the most sensitive sequence for acute infarct, you will not tell CT. You will not tell T2 weighted or flare. You will tell diffusion weighted. Okay? So why is it diffusion weighted? In the first 30, diffusion weighted becomes positive after 30 minutes of infarct. So see how sensitive it is? How early you can detect an infarct. That is why you do these sequences and put the patient on TPA. And the patient could recover completely. So it peaks 3 to 5 days and it remains positive for 2 weeks. The diffusion weighted remains positive for 2 weeks. ADC that I just showed you normalizes, becomes isodense like the brain in 7 days. So this tells you within 7 days, ADC if it is low and diffusion weighted it is bright, it is acute infarct. After 7 days, ADC will become normal. So you will not be able to tell it is acute. Or if you see bright on ADC, it is not acute. Okay. Now why do we do this? Because CT cannot tell you about infarct in the first 2 to 6 hours. Availability. If you have an MR, you can do this, diffusion weighted image. But most trauma centers don't have this MR facility. MR is safe and there's no radiation involved. It's an advantage. Time consuming. MR is more time consuming. CT is less time consuming. So usually what they do is they do a CT and they don't find anything. They are assured this is not hemorrhage, so they put them on anticoagulants or aspirin. They don't do an MR immediately. They do an MR later on. Get an appointment and do an MR. Okay? So it depends on where you practice. What sort of practice is there? Now, probably the second last or last, non-contrast CT scan of the brain, 50-year-old man with history of acute onset of left-sided weakness is performed in emergency department, revealing area of hypertensity in the right basal ganglia and surrounding edema. So what do you think it is? Hypertensive bleed. Okay, this is another example of bleed. This is another example of a bleed. This you read in the first one, so I'll not go into detail. What is this? Hemorrhage again. Why? CT, it is white. On MR T1, you see, you hardly see it. And this is the late sequence hemosiderin sequence, which is sensitive for chronic hemorrhage. Now, what is this? Ring enhancing lesion in the frontal region with surrounding edema. Complex cyst or abscess. It's an abscess. So this is a child which had frontal sinusitis and had a ring enhancing lesion with surrounding vasogenic edema. So which one will you choose? Pyogenic abscess. It has come from the frontal sinus. This is another example of an abscess, but this time you also see air inside. Okay. 30-year-old woman with past history of spontaneous, someone was asking about venous infarcts. Okay, so if you have cerebral venous thrombosis, okay, the infarct is hemorrhagic infarct. So when you see hemorrhagic infarct, it is usually cerebral venous thrombosis. So example from this is, which one will you choose? Cerebral venous thrombosis. Hemorrhagic infarcts, when you see hemorrhagic infarct, it is usually associated with cerebral venous thrombosis. You see, this is the transverse sinus draining the brain, and you see hemorrhage here. You see there's an infarct here with hemorrhage here. You see infarct with hemorrhage here. So this is dense transverse sinus, cerebral venous thrombosis. So if you see hemorrhagic infarct in an atypical area like this, or in the peripheral thrombosis, usually these are females taking anticoagulants. You do a MRV. MRV, remember from my first lecture? The transverse sinus on this side is absent. So there is thrombus, there is no flow in this sinus. There is no blood draining the brain on this side. So this side is patent. This is the transverse sinus, sigmoid sinus, internal jugular vein. You don't see these structures on this side because they are thrombosed. This is the anatomy that I showed you, superior sagittal, inferior sagittal. This is the confluence, transverse sinus, sigmoid, and then they drain into internal jugular. This is the sagittal image. Okay, last one. This is I think I showed you, a lesion inside the cord. What do you think it is? Yes. Is it an infection or is it a tumor? Why? Intramedullary, and it is expanding the cord. You see the cord here is being expanded. So which tumors did I tell you on the ependymoma and astrocytoma? So the ones that are common in the cervical cord is ependymoma. Okay, so if you get an option of a tumor or ependymoma, click on that. Clear?
Clear.
Okay.